Hey everybody, it's Dr. Becker. We're going to jump now into then chapter 56. In chapter 54, we did a really deep dive review into the immune system and covered a whole lot of terms. Now jumping into antihistamines is actually pretty simple and straightforward. If you think about the antihistamines we've covered before, part of that briefly in the GI content. But now we're focusing on antihistamines in the role of allergies and how to use it for like allergic rhinitis. In general, when we think of antihistamines, then we think of a couple of things in general. When you think of them as a drug class, number one, they're either H1 or H2 antagonists, but we still use the term antihistamine. But technically speaking, they're H1 like antagonist drugs, but we still call them antihistamines. When you use an antihistamine, you can use it for either things like the gastric acid issues that we talked about in the GI, so we're not going to review that much at all here today. Then you think of allergies. For the purpose of this book, your book kind of dives into, there's two different types of allergies. So we have like our mild or moderate allergies. Those are things that we get every day in real life that are over-the-counter kind of medications that we would take to treat. So think of things like your seasonal allergic rhinitis, hay fever, exposures to ragweed. I got stung by a bee. I got into some poison ivy, right? Those are those mild to moderate allergic kind of reactions that we have typically to our environment or those things. Then we have the second group would be considered like severe anaphylaxis, and that is a whole different ball of worms, so to speak. So when we really get into the depth of this chapter, we're really talking about treating like our seasonal allergic rhinitis. The purpose of this chapter is to understand how these drugs work in the body is more than anything of what we cover. This is a pretty kind of simple, straightforward kind of chapter, but I feel like it reads kind of funny. But they start with just the discussion of histamine and what it is and how does it work in our body. So histamine is a mediator that our body releases that has varied effects. In our vascular system, it causes small vessel dilation, so vasodilation of our capillaries and like venules, and it causes increased capillary permeability, which leads to the fluid leaking out into the tissues and like edema. Okay, so in our periphery, in our vascular system, it causes vasodilation and edema, increased capillary permeability. Okay, then histamine works in our bronchi in the lungs. It produces constriction of the smooth muscle. Okay, so we have our vascular system, our lungs now, and then in the stomach, we know that histamine stimulates secretion of bile acids and gastric acids in the stomach. Histamine also can affect our CNS and can act as a neurotransmitter. So there's a wide variety of places in the body. And so when we say you have a histamine release, and where and what are those symptoms going to look like could be varied depending on where it's acting locally in the body. Okay. We use antihistamines generally for the general allergies and then like peptic ulcer disease. Okay. When we're talking about histamine in general, remember that histamine is synthesized and stored in our mast cells and our basophils, which is what we talked about in the previous chapter. Mast cells are present in the skin and soft tissue, but basophils are what remains in the blood. Okay, both mast cells and basophils, histamine is stored in these secretory granules, which is what we're going to talk about in this slide here. These are these secretory granules that contain our histamine within a mast cell. Okay, that's what this picture is representing. You can have histamine be released. You know, the process of triggering the release of histamine can be from allergic and non-allergic mechanisms. So the main one we think about mostly is an allergic release. So that's why we talked kind of about an allergen and an antigen and an antibody in that previous chapter. So the initial requirement for allergy to be the cause of histamine release is when you've produced antibodies of immunoglobulin E. So when we're thinking allergies and immunoglobulins, it's E. those antibodies are generated after an exposure to a specific allergen, right? So like we talked about in chapter 54, when you first get in that exposure, your production of your antibodies is low because you don't have a lot ready, quote unquote, at the moment. It's a new experience for it. So it's the second exposure that then causes this big allergic reaction to occur, because we've had those memory cells now and we're ready to mount a big response with a big histamine reaction to the second or subsequent allergen exposure. Once made, the antibodies become attached, right? So it makes this antibody. And once those are made, those antibodies now become attached to the outside of the mast cell or the basophil. In this example, it's the mast cell. So when I'm now, this is at the first time, okay? So my first time maybe that I got stung by a bee, it made the IgE antibody. Those were sticking onto the mast cells, and then I get a second down the line. I get re-exposed to that allergen, and now all of these are here and ready to go. So when I'm exposed again to the allergen then becomes bound to these antibodies here on the surface. The binding of the allergen to the antibodies creates a bridge between these antibodies, which is kind of hard to see here what they're talking about, but it would be like these all kind of become connected. They don't really fully understand how this works, but they know that the bridging process mobilizes intracellular calcium, and then that calcium causes this histamine granule to fuse here to the outside of the membrane, and then it disgorges, I love how they say that word, it like vomits out the histamine into this extracellular space, and that's how now you have a histamine release, okay? So an allergic reaction of histamine requires prior exposure to the allergen. An allergic reaction cannot occur during your initial allergen exposure. So if I get a histamine release caused by an allergen, this is what this looks like here. Now, you can have a non-allergic release, and those are things that are that cause direct cell injury, such as certain drugs, radiocontrast, or plasma expanders, and those can act directly on the mast cells and trigger some cellular damage here and cause this release of the histamine. So that can happen when you've never had it before, and it's not a true allergy reaction in terms of a response of the immune system to an allergen. So they refer to that as non-allergic release of histamine. Okay. So that's kind of where the book starts off with us. It's helping us review how you come to have histamine release in your body, and physiologically now, what does that look like? So this event has occurred. Let's focus on an allergy, ragweed, pollen dander, cat dander, whatever. I'm experiencing it again. This is happening. This has all been triggered now. Now I've released this histamine. Okay. So now histamine has two types of receptors, which is where we get H1 and H2. So depending on where the histamine binds, produces what effect we're going to get. Okay. So we start with the effects of H1. So H1 stimulation. So histamine 1. When histamine binds to an H1 receptor, that is where we get vasodilation, increased capillary permeability, bronchoconstriction, central nervous activation, and like hives and some of the pain or itching of the skin. Okay. So vasodilation, let me make you guys a new slide here. Let's call this then effects of H1. Okay, so vasodilation, that's where you get the arterioles and the venules get dilated and we get that flushing and redness. It typically happens in the trunk, so arms, upper chest, neck, and face. You don't typically see somebody having an allergic reaction to the release of histamine and they get like bright red feet, right? It tends to happen up top. It can kind of happen a whole body, but it's more prominent in the upper extremities and face. We know that if it becomes extensive in whole body, then that's when we can also get blood pressure decreasing. So H1 stimulation causes our vasodilation, and then it causes that increased capillary permeability. So the receptor activation, H1 receptor activation, causes the capillary endothelial cells to contract, and that creates opening between those cells that are supposed to be touching. So you have fluid, protein, and platelets escape, and that extra fluid and protein into your interstitial space is what causes your edema. We know if you have extensive permeability and extensive loss of intravascular fluid to the extravascular space, then your blood pressure could fall. Okay. There is a role of H1 in the lungs, like we said before. So H1 activation, receptor activation, causes constriction of your bronchi. If histamine is administered to an individual with asthma, severe bronchoconstriction will follow. However, exogenous histamine can induce bronchial constriction, but histamine in terms of asthma is not at play. So people don't have asthma because they get internal histamine release. Okay? The mechanism of action and the cause of the pathophysiology of asthma is not because of histamine. So in general terms, an asthmatic patient you're not going to treat those symptoms caused by asthma by an antihistamine, is what the book is trying to tell us there. So that's the distinction they're making. But when you are having an allergic reaction to something and you have this excess surge of histamine release, you can get that bronchoconstriction because of the histamine effect. We know that there are H1 receptors that are in the brain, and that's when we get the histamine binds to that, and you can have cognition, memory impairment, sleep or wake issues. It can even have effects on our endocrine system as well. The other thing that happens with activation of H1 receptors in general, especially when they're on the sensory nerves, is that's where you get itching, pain, and like hives. And it also can promote secretion of mucus. So that's why people get runny noses. That's why you get like you're coughing up phlegm, or you kind of get that yucky in your upper airway stuff. This is also from the H1 receptor activation. Okay. When we talk about H2 receptor activation, that is where we're talking about the GI stuff. So H2 blockers, like famotidine, is what we're doing. If we block that H2 receptor, then we reduce the amount of gastric acid being released. So histamine does act directly on parietal cells of the stomach through the H2 receptor, and that promotes acid release. Okay, so that is kind of what we talked about in the GI section, the H2 stimulation. If we give an H2 blocker, we block off the ability to create that extra gastric acid. So if someone's having peptic ulcer or gastritis, heartburn, right, you give them an H2 blocker, and that's how that's working. So when we say that someone is having an allergic reaction, right now, we're focusing on histamine in the role of an allergic response. The truth of it is that there's other compounds and mediators that could be at play. So we know sometimes it's leukotrienes, prostaglandins, cytokines, tryptase, those other mediators. For the most part, histamine is the bigger driver for these routine kind of everyday occurring allergies, but not always. So some people don't respond completely and get total satisfaction just from taking antihistamines because they probably have then more leukotriene or prostaglandins at play. But for the purpose of what we're talking about, our mild allergic reactions, histamine is at the forefront, so we get good response after giving an antihistamine. So we have the two types of antihistamine. So again, we use this word antihistamine, which is the same as an H1 or H2 antagonist, okay? So when we give something that is an antagonist, what we're talking about is we're blocking the H1 receptor. So if I give an H1 antagonist, some people will still call it an antihistamine, but specifically at the H1 receptor sites, we are blocking that, so histamine cannot bind to the receptor. For H2 antagonists, people still use the general term antihistamine, but this is where we would be blocking the H2 receptors. So when people use this term interchangeably, it is kind of not truly representative of what we're doing. So when we say I'm given an H1 antagonist like diphenhydramine, I am blocking H1 receptors, and I'm going to be using that to treat these mild allergy symptoms. But if I give an H2 antagonist, I'm going to use that for the treatment of gastric issues. Okay, so for the purpose of this book, we're really trying to focus on the H1 part. Okay, so when you get that role of histamine, again, like I said, what's happening when you get that flood of histamine into the system and it's binding at all these sites of H1 receptors? We get runny nose, itching, edema are the big ones that we see directly from that. If someone's having an anaphylactic reaction and then you get that big histamine response, then you can also see bronchoconstriction, hypotension, and edema. Histamine plays a minor role, though, in the severe anaphylactic reaction, so that's why we treat with epinephrine. The antihistamines aren't going to be enough to counteract a severe anaphylactic reaction, is what they're saying. So let's talk about the basic pharmacology. If I give an H1 antagonist drug, okay, H1 antagonist drug. When we talk about the H1s, we have two generations. This is really H1 antagonist first generations, and then second generation H1 antagonists. Okay, the biggest difference, H1 sedating, H1 first generation sedating. H1 second generation are not sedating. That's the biggest distinction between them. When we first came up with H1 antagonists, antihistamines, unfortunately, they were very large molecules with low, they were very small molecules with high lipid solubility, and they could cross the blood-brain barrier easily. And because of that, you had those sedation side effects. So the people that are smarter than me figured out a way to make that second generation where they made the molecules much bigger with a low lipid solubility, so they don't cross the blood-brain barrier and you don't get the sedating side effects. So that's the biggest difference between first generation and second generation, is whether or not there's sedation. Okay. Both of these are going to block the H1 histaminic receptors, and so they're blocking the action of histamine. So we're blocking the ability to cause the vasodilation, the permeability with edema, those things. But they do not block H2 receptors, right? So if I give diphenhydramine in H1 first generation, I'm not going to reduce their gastric acid. Okay. Also to note, when you give an H1 antagonist, they do not block release of histamine from the mast cells or the basophils. So if this has already happened to cause this histamine release, and by giving a blocker down the road down here, it doesn't change whether or not this part keeps happening. So I hope that makes sense. When we're given an antihistamine, we're working downstream on the blockers. It doesn't change the amount of histamine that has been able to be degorged from the mast cell. The other interesting thing about the H1 blockers or the antagonists is that they also bind to non-histaminic H receptors that can bind and block muscarinic receptors. So you can get these anticholinergic side effects as well. All right, so when I give an H1 antagonist and I'm blocking the H1 receptor, what happens? I decrease my vasodilation, right? So I no longer have my arterioles and my venules of the skin vasodilating, so I decrease flushing. Okay. Once I give that blocker, I prevent the increased permeability and I should have a reduction of edema. When I give that drug, I should block the sensory nerve H1 block receptor there. So I should have reduction of itching, hives, or pain. And when I give it the H1 receptors, my mucous membranes should have decreased secretion. So my runny nose should decrease. My itchy, watery eyes should decrease because I'm blocking those receptors. So I know if histamine was allowed to attach to the H1, I get the vasodilation, the edema, the increased mucus, etc. But now I block it and it can no longer attach to the H1 receptor. So I should see a reduction of those symptoms. It doesn't change the amount of free circulating histamine that's still being released from the mast cells in my exposure to my allergen, though. But I am decreasing the ability of that histamine to now cause problems. These H1 antagonists that are the first generation, they can cause both excitation and depression of the CNS. So at our normal therapeutic doses that we use for allergies, they can produce drowsiness. But if you get into an overdose or toxic levels of medication, they can cause a significant excitation. It is negligible in the second generation. The hard part, though, is that CNS depression can be occurring from the medication use, but doesn't always make someone feel very sleepy. So that can be a problem if people are regularly taking an H1 first generation, because they may not feel sleepy or tired at all, but they can still have reduced reaction time that's even similar to like being over the legal limit of alcohol. So we really do advise people not to use them and drive or have to make those kind of critical decisions, etc. So when do we use H1 antagonists? When do I want to give someone an H1 receptor blocker? Well, it's to people that are having allergy disorders, right? So seasonal allergy rhinitis, seasonal allergies, dander, those kind of things. There are some use other than allergies. One of them is motion sickness. So some of those, specifically promethazine, which is Phenergan, and dimenhydrinate, which is Dramamine, are labeled for use in motion sickness because blocking the H1 receptors and muscarinic receptors that they do in neuronal pathways that lead from the vestibular apparatus in our ear down to the vomiting center of the medulla, we can help impair that and have an improvement in motion sickness. We use them in the mild allergy situations. So people with allergic rhinitis, runny nose, itchy eyes, watering eyes, hives, redness, flushing, itching, those kind of things can be improved by giving a H1 antagonist. Practically every over-the-counter sleep aid on the market has some form of an H1 first-generation antagonist because it's going to help hopefully induce someone to be sleepy. But really they're insufficient doses and they're not really all that effective for people, but people use them all the time. The problem is that you can also have bad effects from the H1 blockers for both first generation and second generation. The first generation tend to have more side effects. Table 56.1 in your book gives you a nice table there to kind of understand how much blocking activity the drug has, how much of a sedative effect it has, and anticholinergic effects. So if you go through those, the alkylamines, those are like chlorpheniramine, brompheniramine. Those are ones you see commonly in cold medications. Your ethanolamines, which is where your diphenhydramine is, and then phenothiazine is where promethazine is, piperazine is where hydroxyzine is. But you can go through and see that maybe like chlorpheniramine, which is like what we see a lot in cold medicines, they have only a milder sedative effect, so people can tolerate those much better. But if you give someone diphenhydramine, it has 3 times the sedative effect, which is why people use that as a sleep aid, right? When you go into your second generation on that table, you're going to see the 5 that are available on the market. They're very similar in the sedative and anticholinergic profile, and they're also very similar in their H1 blocking activity. So maybe loratadine and desloratadine may be a little less effective than cetirizine, levocetirizine, and fexofenadine, but they're all pretty good. Cetirizine is said to have the lowest sedative effects of all of them. From these drugs, the H1 are going to be on the Beers list because if we give them to elderly people, and the sedation is often not what we want, because that is the most common side effects and can lead to serious consequences. There is a degree for people to develop a tolerance to the sedation after a few days or weeks of using it. So that is kind of good in some ways if you have to use it routinely. The non-sedative central nervous system effects can cause things like dizziness, incoordination, confusion, fatigue. You can have it in anybody, but typically younger kids or older adults can have a paradoxical excitation where they actually go a little nutty. It's like meth to them. It's like nervousness, tremors, anxiety. They get way revved up on it. It doesn't go well, and like you don't want to give it to them. And it's really hard to know. And plus, if they're taking too much of it, you could have some serious kind of unexpected paradoxical effects from those medicines. Again, the other issue that makes it the most intolerable to people, in other words, the adverse effects that make people want to quit taking the medication tends to be the anticholinergic effects. These drugs, especially the first generation, they can dry you out, your mouth, your nasal passages, the back of your throat, but they can also cause urinary hesitancy or retention. It can cause constipation. They can also cause heart palpitations. So those are oftentimes, if people say, I can't take that medicine anymore, it's because of these anticholinergic effects. You have to be careful giving the first generation ones to asthmatics, again, because of some of those issues with increased mucus secretions. And you have to be careful giving these medications, especially the first generation, to people that have like chronic urinary retention or BPH, or really difficult to control high blood pressure. Remember that promethazine, which is Phenergan, is an first generation H1 antagonist, and it does carry a black box warning because it can cause severe respiratory depression, especially in very young people. It's actually contraindicated in less than 2. In my experience, it's not really used in anybody less than 12, unless it's a very specific situation. Like I have known of it to be used like in the oncology realm and some of those things. So it's not that it's a never, but those are very unique, specialized situations. And I'm willing to bet if they're used, the children are monitored very closely, like in a hospital setting. Phenergan or promethazine is not going to be your first antiemetic drug of choice to give to a 10-year-old for whatever reason. The other thing about it is, yes, it can cause the severe respiratory depression, and I've seen this in older adults. I don't really like Phenergan. It's in my toolbox. It is a medicine that I would give, and I have given, but it's not my first drug of choice ever. The main time that I've used it mostly is in cancer-induced or chemotherapy-induced nausea and vomiting. But remember, it does follow under being an H1 antagonist, and it has the black box warning. Obviously, we also have to be careful with these drugs with anything else that's going to cause sedation, drugs, alcohol, or other depressant type drugs like muscle relaxers. There's not good data for us in pregnancy and lactation. There is some concern that it could cause some fetal effects if taken during pregnancy, and there is a small amount that does go into the breast milk. I've always been told that you can, few and far between in lactation. But again, it's not something I would routinely advocate for somebody to use outside of the role of their specialist. Table 56.2 is nice in your book as well because it goes down and breaks through what these like trade names are as well, because people really still use the trade name quite a bit. And then the only other part really to talk about is that your book goes into talking about the second generation non-sedating. They talk about fexofenadine as their prototype drug because it was the first drug on the market. And it's pretty safe, pretty effective. People can have a good response to it. The big thing is that it can have some bad disruption to absorption if you take it with fruit drinks. So they say no apple juice, orange juice, those things around the time that you're taking that as well. The summary of key prescribing considerations is a really good one as well at the back of your book to kind of have a general review of how we use those medicines. So this was pretty quick and pretty easy. What I want you to understand, again, is that, how do we get to mast cells? How do we get to the basophils? How is the histamine released into our body? Understanding the concept that when we give an antihistamine, what we're truly giving is an H1 antagonist or an H1 or H2 receptor blocker. We're not giving an anti-production of histamine. We're just preventing the histamine to bind to the receptor. And that's a distinction. And these are the medicines that we cover for simple things like routine, seasonal allergies, mild allergies, etc. Any more for over-the-counter routine things, almost always people are going to the second generations. I don't know why you wouldn't. There's some specific indications of when you would take Benadryl for some other things, but for the most part, we default to our second generations. I use second generations a lot in my older adults. I love the cetirizine because it's probably the least sedating, and even then it's negligible. People tolerate it well. I feel my elderly, frailer patients can tolerate it pretty darn well, really with minimal side effects. So that's in my personal toolbox what I like to default to as my first drug of choice over like fexofenadine or whatever. I tend to go with the cetirizine. But that's it. That's a pretty straightforward section here. So as always, let me know if any questions or concerns.